unmarried resident of Mumbai, presented to emergency department with chief complaints of dysuria and lower urinary tract symptoms since 10 days.
So he had complaints since only 10 days. And lower urinary tract symptoms means which one? Like voiding symptoms or storage symptoms? Which was?
He had increased frequency, urgency, and nocturia. Also, he had straining with intermittent steam, which was associated with dysuria and post-void dribbling. And it was associated with fever with chills.
Fever with chills. Increased frequency means how, what was the frequency, and he had only a night frequency, or because
he had both frequency during day as well as night, around 10 to 12 times per day and 5 to 6 times during night.
Straining and intermittent stream. This also he developed 10 days, or previously also he had this straining to void, or
all the symptoms are only since 10 days.
Had any hematuria? Any
No.
history of, any history of flank pain or anything?
No flank pain.
Any history of any lithuria previously, or passage of stones or anything?
No.
Kamraj is answering, right?
No, Harish is answering.
Acha, Harish. So why are you going to, like with this, I think the diagnosis is obvious. Why are you asking for lithuria and all these things?
Yes, increased frequency, urgency, and only 10 days this one, and along with that straining and intermittent stream, there might be a prostatic urethral also associated. But only thing is dysuria.
Will it present with dysuria, fever with chills, or
fever with chills,
pain, abdominal urine retention? Okay,
no.
What it could be. What else? When there are LUTs associated with fever with chills, what should come to your mind first?
Possibly cystitis, ma'am. Cystitis, and since he's a young and 10 days,
21 male person, cystitis is the first thing which comes to your mind. Why?
Prostatitis, ma'am.
Okay, prostatitis. Why?
Because he's a young, straining to void, frequency, urgency, nocturia, and with fever with chills. So most commonly it will be prostatitis, and second probably might be cystitis also.
It's very unusual for prostatitis to be isolated away from cystitis.
Yes.
Yeah, you see. That's why in the older books they used to always write prostatosemilulovesiculitis. The old books will combine everything, itis, cystitis, itis, everything. So it's usually with that when you say prostatitis. Okay.
So any other male genital organ?
Think of something else. 10 days history. 10 days history.
10 days history, fever with chills, LUTs.
Maybe this unmarried.
Unmarried, yeah. 21-year-old unmarried, they said. No?
Yes.
Marriage has no relation, Mama.
What else?
What else?
There are important considerations in a situation like this.
It's a sexual history also.
Ask for sexual history. You think a 21-year-old fellow living in Mumbai is a saint? Eh? Even 21 in Coimbatore are not saints. Both sexes, by the way. Both sexes.
What about his sexual history actually? Whether he's sexually active or?
Yeah, he had a history of unprotected sexual intercourse before 2 weeks.
So after that, he started having all the symptoms.
Okay, any more history you want to ask? So I'm telling you, I want to know what comes to your mind when you say fever with chills and LUTs. So once you said prostatitis, cystitis, you accepted. Prostatic calculus didn't accept 100%. So what else can come to your mind? What have you seen in this age group? History of unprotected sexual intercourse, 10 days.
Other than that,
what leading questions you are going to ask?
Yeah, leading question.
He knew that history. What is the next question you will ask based on that history is the question.
Any urethral discharge is
Okay, very good. Any urethral discharge? Yes. Anything else more specific?
any lesion on the glands.
Yeah, right.
Okay, yeah. What
What
else?
else? This is the topic on venereal disease in urology. You know that topic is there, genitalia, male genitalia and venereal disease. There's one section in textbooks. It's very important to ask the history accurately in this one. Please give me a history.
Any vesicles which are there.
Huh?
Any other skin lesions?
No,
which
did
are
he
there?
have first of all protected sex or
They told you,
unprotected sex?
unprotected
They said
sex.
unprotected
Yes.
sex. Okay, right. Okay, right. Then
Unprotected sexual intercourse.
with whom? With whom? Very important. Was it his first time or is it many times? There's a lot of difference between having unprotected sex with a woman for the first time. And how do you know it is only woman? Have you asked?
No, sir.
Those are the questions that have to come out in today's world. In today's world. Last but not least, don't forget, I may have had unprotected sex, but nothing happened to me, but I got COVID. COVID can also have shown this presentation with COVID disease, 10 days. Fever, dysuria, burning, all the rest of it, UTI, all this going on. A whole gamut of conditions will present like this in your 21-year-old. So the history is very, very important. What are the other questions history will ask? You ask for discharge.
What
I
else
gave
would
you some tips. Some more. I didn't give you all the tips. What else did you do? Huh?
Any anal intercourse or anything? like
Okay,
that.
ask. Yeah, that's right.
And, any
He would have been
catheterization?
there. He would not have been sodomized. He would have been superior, this fellow. If at all we're looking at any intercourse. Anything else?
Any previous history of any catheterization or any during that time
Catheterization.
can also give rise to prostatitis, but direct history.
No, he's told you that. He's gone 10 days ago history, he's come to the emergency. 2 weeks, 2 weeks ago, he had unprotected sex. Take the story from there. You ask for this, anything else? That's why I told you the topic on venereal is very important.
when you have fever with chills and LUTs, what are the organs in urology which can be involved apart from the things you have told?
Ma'am, but no flank pain, they told ma'am already.
Flank pain, forget. Anything else?
There is semen and vesicles.
Seminal vesicles
Again, epididymoarthritis, ma'am. Epididymoarthritis can
you have to
also.
ask. Isn't that commonly seen?
Yes, ma'am. Actually,
Then how can you forget? Okay.
scrotus.
Okay, we'll just proceed because of lack of time to the next slide.
There's no history of hematuria, pyuria, or lithuria. No history of flank pain.
Okay, go to the next slide.
Next slide. Normal. Next slide.
Correct. Abdomen.
For abdomen examination, abdomen was soft, non-tender, no lump palpable or aganimically. On genital examination, external urethral meatus was normal, diffuse retractile normal, bilateral testes were normal. On DRE, anal tone was normal, with grade 2 prostate, soft consistency, tender, smooth, rectal mucosa free, no fecal, BCR normal, and focal neurological examination was also normal.
Everything is normal.
No, it's not normal. Everything is not normal. How can you say normal?
Too soft in soft in consistency.
Arey Baba, grade 2 soft tender.
Tender, yes, sir.
You forgot tender. What is soft?
Normal, no?
Soft and
Soft
tender.
and tender means what?
Probably there is a Pus, sir. Actually, usually it's a firm in consistency and soft
We don't know. Maybe there's an abscess there.
abscess, prostatic abscess.
You are diagnosed for acute prostatitis at one point, and the findings are of a tender prostate, grade 2,
Yes, sir.
means it's not grade 1. It's more than grade 1. It is large for a 21-year-old man. And that is soft. So, are we dealing with an abscess in evolution in that prostate? Or is it already there? Because the history is very classical. Huh?
Yes.
So don't ignore the lines which are put there. Very important. So now what do you do?
I would like to have the urine routine and urine culture, sir. Actually.
What's your diagnosis?
Probably a prostatic abscess, sir. Evolving prostatic abscess, sir.
Why not seminal vesicle abscess? Why not prostatic abscess?
But
You have to ask him, na? Was there something felt above the prostate?
but they are told, prostate only is soft in consistency and tender. So prostatic abscess examination.
Tell you everything.
I'm just raising a point here. Supposing this fellow was sodomized and he got an abscess around the rectum. Yes, we've seen these fistula and anal tracking and presenting like periurethral abscess and in the space between the prostate and the rectum. Don't know.
Yeah, it can
We
be.
don't know whether he had a pre-existing fistula and ano or something else.
See, prostate tender doesn't mean that the prostate itself is tender. It may be
Between that area.
It can be in that area. What else is there? Seminal vesicles are there above the prostate.
Rectum because yes, ma'am.
Whether it is palpable. He may not tell you everything,
Yes, ma'am.
Okay, so you want urine routine.
Urine routine and urine culture, ma'am. Actually.
Culture
We
was
had come to emergency, so right now we don't have culture.
Okay. And serum creatinine also.
Why creatinine? That's the only investigation you want after urine routine.
For routine workup, ma'am. Actually. And also if any further.
He may be HIV positive. Then he may be hemophilic, for all you know. There's having bleeding over there. So at least ask for routine things, HB, CBC, let that come in a flow. For that you have to ask anyway.
No, fever with chills.
Total
you want
count.
to know at least what is white cell count.
White cell count.
What
why
was
are you not understanding? Why are you mentioning only creatinine, nothing else?
Yes.
Oh.
23,000.
23,000 count.
Creatinine.
So these things have to come. You have to ask for HCV, HIV.
Yes, ma'am.
Count. Can't forget count.
Since his counts are elevated, first we would like to treat him with the antibiotics, ma'am. Before that, we want to assess the prostate whether there is abscess or not. We would like to do a TRUS scan if available.
We will allow you to do TRUS.
Yes.
No, he is refusing. So tell us something else.
If it's then, ma'am.
That probe in the rectum, won't it cause more pain?
Yes, ma'am.
So when there are other investigations.
There's another investigation in the situation that we are faced with.
First,
The way to answer this question is, I would like to do a transrectal ultrasound. However, the probe size and the tenderness will preclude this test from being done, and therefore I would prefer to do this particular investigation. And answering that will tell the examiner that you know that there's a test called TRUS. You know the problems of TRUS in this fellow, and therefore you are going for that.
Yeah.
Investigation, we can go ahead with the ultrasound abdomen.
Okay.
Through the abdomen, we can assess the prostate, and
Okay,
also
you
it will give
you can
the
do that, yes.
it will give the PVR also,
Okay.
post-clot residue which is there.
So you
for
just
the-
want to do a transabdominal ultrasound and see if you can access the prostate and make a diagnosis on that. All right.
and also assess
If
the
it is
PVR.
not possible, if the window is not good enough or whatever it is, he's got PVR maybe, but he may not be able to be sure.
Then,
So in that situation, what you'll do?
then we have to put a SPC for him, sir. If at all high PVR, then
No. You have to make a diagnosis.
you know,
Can't just put an SPC.
Before putting
Hey, end
SPC,
up putting an SPC. You need to have some diagnosis in hand, no?
then if ultrasound is possible, then CT will be the better option, sir.
I will do CT or MRI.
CT, sir.
You want to do CT scan? He wants to do CT scan.
Tell the right investigation. CT what? Urograph.
No, CT of the pelvis actually.
Okay. See, it can be also an appendix, a pelvic abscess. A pelvic appendix which has ruptured, no? So
Yes, ma'am.
your diagnosis is not sure. Don't put an SPC as the first thing. For all you know, this guy must be in sepsis. He may
Yes,
not have a urine output.
But if at all high PVR, ma'am, usually the intermittency and straining toward was there. So if at all he has high PVR, then
We don't know. Post-void dribbling doesn't mean high PVR. Straining also doesn't mean high PVR.
yes, ma'am.
Yeah? Okay, tell him.
So this was the USG done in emergency.
And you want sees it.
Yes. These are the images available.
There is a hypodense most probably loculated collection in the region of the prostate, ma'am. But upper which is involving both the lobes of the prostate and extending probably to the. It is well localized, sir. Not extending, but the muscle planes are well maintained along the side of the
Very prostatic.
very prostatic. Yes. And anterior also it is well distinct, different.
Is the prostate enlarged?
Yes, sir.
So the first thing you say, the prostate is enlarged. It's not a small prostate. It fits in with your clinical picture of grade 2. The prostate is enlarged and shows multiple
Loculated, probably
hypodense
hypodense
areas,
areas,
yes, in the prostate,
along with
in both lobes.
in both.
Now this is you're looking at a axial section. If you had a coronal or a sagittal section, you may be able to see whether these are all mixing together. In one of these cuts, it looks as though one abscess is communicating with the other one across. Okay? It may be just a phase. I think it looks, one of the cuts shows that, like a saddlebag.
ये देखो.
See that? You see that? Huh? So,
Come there. See, 1 minute. Just come there. ये क्या हो रहा है?
what is there inside?
That's probably
Those
bowel
are
coming
bowel
in,
loops.
bowel
No,
loops.
bowel loops. What is that black thing there?
This one.
Inside that area.
That is probably a gas forming this one, sir, in the abscess.
Isn't
if
that an
at all.
important finding?
Yes, sir.
Yeah?
Bowel loops are coming in.
True. All loops are coming inside. In the way.
What about the bladder?
Bladder is partially distended, ma'am, not fully,
Anything else?
and no wall or
No, no wall.
no, ma'am. Walls are no appears to be normal, and there is no interluminal any hyperdense or any enhancing lesions which are there.
Okay, I would call it a
Measurement, unless it is a measurement of the wall, eyeballing that bladder looks as though that bladder wall is thickened.
looks as a
Common sense will tell you that the bladder wall will be thickened because there will be edema in the bladder. And that itself will make the bladder mucosa and bladder wall thick. Such a big lesion there in the prostate, the bladder is not going to be sitting and smiling and watching it, isn't it? He's got dysuria, he's got fever chills, difficulty in urination. So this will definitely involve the bladder, isn't it? So what will you do now?
Since the abscess is large, after evaluating, TUR deroofing can be done, sir.
You will do transurethral deroofing.
But since
Is it
we have to counsel
okay? I
the-
mean, look, think of the possibilities. Now you have got to don't shoot from the hip. Look at the entire case in perspective. All right.
So you
Don't
said you
don't blame this man because he went and had a pleasurable experience. Don't take it out on him.
we have to counsel him, there may be retrograde ejaculation of this
Ah.
TUR deroofing, sir.
Yeah. So what will you do? Is there any other alternative?
The transrectal aspiration, minimal invasive aspiration can be tried, sir. That abscess is
But he is not allowing the transrectal probe to go inside.
perineal approach can
How will you just blindly? Yeah?
ultrasound.
He's not allowing the ultrasound to go inside the rectum.
what else will you do?
Can't you do it under anesthesia, man? Huh? You do under ultrasound for some patients, you do price with that fellow, you put under anesthesia. You put the probe and it. Huh? No, why is it important in this patient to be slightly conservative in your approach?
Because of the retrograde ejaculation.
One
we
is
might-
retrograde ejaculation, which is a serious problem. Number two, any other reason?
Transurethral may lead to.
No. Is he a diabetic?
No, sir. No.
Not a
no,
diabetic.
it is, no.
So what's the other reason?
immuno-
For this, you must understand the workings of the prostate and acute prostatitis. There's a difference between antibiotic coverage in acute prostatitis and chronic prostatitis. You may know that. We are not talking of all this pelvic pain. We are talking of genuine acute prostatitis, genuine chronic prostatitis. Two different conditions.
Chronic prostatitis we are using for a long term, sir. Actually 4 weeks.
No, that's not the answer.
Fine.
That's not the answer. Is the prostate a vascular organ or avascular organ?
So vascular.
Extremely vascular organ. Right. So is there an advantage of having an extremely vascular organ when there is inflammation in it and there is infection?
And using of IV antibiotics to penetrate.
Exactly. So how will you, in this patient, 21-year-old fellow, history of sexual activity, following on he develops a prostatic abscess. Is there another way of treating him rather than putting the scope and ramming him?
With treat him with IV antibiotics and
No. What antibiotic will you give?
so preferably fluoroquinolones are the better in.
Hey, Baba, he's got abscess. Don't you want to aspirate it? Huh? Haven't you done this in your own hospital here, in your own training?
Yes, sir.
Then why can't you answer that?
You wanted to do transrectal or transperineal aspiration, which patient is not allowing under
Local.
local.
You under anesthesia, you complete the picture. You just left half and left. That's why the examiner is pouncing on you. You left the story half and you went to something else. Take out the abs. I will aspirate all this. Send it for culture. Tell them this fellow has got a history of exposure. They may find live gonorrhea in it. We don't know.
Yeah, so I think you should at this point in time ask for a urethral smear
Yes,
because
ma'am.
the antibiotic would be different, right?
Yes, ma'am.
What is the drug of choice for gonorrhea?
Insulin.
Huh?
Ceftriaxone.
Ceftriaxone. Very good. How many doses? One dose. One dose.
1 dose, 1 gram. Achha, what is the standard treatment which is as per PSM textbooks which is given for STIs when we don't or we can't make a diagnosis? We can't make a diagnosis in a PHC for in a small center in a village. No? You can't make diagnosis of gonorrhea and this and that.
Listen to
Yes,
the question very carefully and answer the question carefully.
What is the recommended?
PSM, preventive social medicine. PHC, patient is coming with this problem. You don't have this scanner, that scanner. What is the drug of choice?
But you are suspecting gonorrhea or something similar. What are the other organisms also you suspect along with gonorrhea? Which can cause similar pictures, STI.
Chlamydia.
Yeah.
Chlamydia.
Chlamydia.
Loudly. Don't be diffident, Harish. You know the answer. Speak loudly.
Gonorrhea, chlamydia,
They're all in the category of non-gonococcal infections. Right?
not gonococcal.
Chlamydia is the most important in that. So now if you know that, what is your answer to the question that ma'am asked?
Macrolides will be the
Which one you will give?
azithromycin.
Choice for gonococcal.
He's sick.
Doxycycline.
Doxycycline. Or better than doxycycline is?
Tetracycline.
No, minocycline. Tetracycline not available. Gone. Match is over. So look at it.
Cycline, azithromycin and metrogyl. That is the combination.
Yes,
So
ma'am.
anaerobics, everything is covered. Yeah? So,
Because you don't know, you can't make a diagnosis.
did you do a biopsy or the aspiration on this fellow? What's the culture? Did you?
Sir, we did transurethral incision and approx 60 to 70 ml pus was drained. Pus culture was no growth. Pus gene expert was also MTP not detected. But we sent some tissue from the floor, which was suggestive on histopathology was suggestive of chronic granulomatous inflammation.
That doesn't mean it's TB. This may be just some reaction to the pus and everything else, granulomatous infection.
Yeah, very likely because of the history of 10 days.
Yeah. And he would have definitely had some antibiotic before he came to see you. Everybody knows that. They know that you have this problem, quickly go and the GP will give them a shot. So
No, sir. Actually, patient just went to GP before 1 day, and then he was referred to our center.
to complete the story, the questions you must ask a patient like this is when exactly did he go? How many times did he go? Was there a lesion in the glands? When did that lesion appear? Was that lesion painful? Was there urethral discharge? Because all this will tell you which is that venereal infection. Is it a chancre? Is it a chancroid? Is it gonorrhea? Syphilis will come little later. But all these infections are still there. All these infections are still there. They haven't disappeared.
And actually, currently the gonococcal is very resistant.
Well, that is why, you know.
Problem is sitting is not something which is easier.
So it's very difficult. That is why the treatment of gonorrhea has changed. In those days, we used to give penicillin. Penicillin was the Ramban for gonorrhea. But it all changed completely. And now we have got this ceftriaxone is what is the recommendation. So, you know, things have changed. Anyway, interesting.
नहीं एक मिनट
Here, most important is the smear, and sometimes it's doing the same aspirate for the genius.
Yes. I would have, frankly, I would not have done TUR for this chap because of the risk of sepsis. 23,000 count, doing a resection is much more dangerous in producing shower of bacteria into the system, into a vascular system, than aspirating. Young fellow, I would have aspirated it first, sent it for culture and sensitivity. It would have not got mixed up with all the other fluids which are there in the theater, and sent it for all the bacteria, whatever he wanted, and then treated him. And if he doesn't respond, because in acute prostatitis, the gland is very vascular. So antibiotics will penetrate beautifully, just like in acute pyelonephritis in kidney. You don't go and drain unless there's an abscess. Even then, if there's an abscess, you give antibiotics to treat because it penetrates. Only thing is treatment is long drawn. A patient like this may develop later on true chronic prostatitis because the prostate will, certain areas of prostate will coalesce, clog up, the ducts will clog, and they will get recurrent discharge. So these are sort of patients who may get genuine chronic prostatitis. And then the prostate shrivels up and becomes small. And if he gets recurrent symptoms, if he goes on and on like this with pain, he may be a candidate for prostatectomy, total prostatectomy. Look at the books, they'll tell you. Chronic prostatitis, intractable, resistant, recalcitrant prostatitis, proven chronic bacterial prostatitis, causing quality of life situation. Not radical prostatectomy we're talking about total prostatectomy. So that this fellow's chronology could be like that. We don't know. Okay. Thank you. Thank you.
Thank you, ma'am.
Nice case. Very nice case. Go back and read about. I think next week something to show that you. Sujata,
Yes, sir.
we had a very interesting.